you have trouble hearing me because my voice doesn't carry really well, but I do have the microphone and I can continue to move it up closer. Um, just to give you a little background, so I've technically been working in New Hampshire up until March of this year, but I've been engaged in long-term care infection prevention actually since 1991. And I don't see many gray hairs out here, but 1991 was kind of a key date in long-term care infection control. Does anybody here remember that? I was lucky because I was hired by a laboratory to work with their long-term care facilities in infection surveillance. And what had happened was the McGear definitions had just been released. The other thing was that the OBRA 87 regulations had come out, and they weren't put into place until 91. So an awful lot was happening, and I felt like the nuns, that I was 1 week ahead of the students. So I had the McGear article, and I could say, here are the key definitions that you need at this point. I wanted to tell you a little bit about what the role of the infection control person, and that's what it was then, nothing about prevention. Back in 1991, what I was seeing, and look at it in terms of how you see things today. Typically, the joke was that the infection control person, somebody such as the assistant director of nurses, or the director of nurses, or the employee health nurse, or the staff development person, or the MDS coordinator, was invited on Friday afternoon into the director of nurses' office and said, you are doing such a good job at what you're doing, we would like you to be the infection control person. Does this sound familiar? And you would think, okay, tell me about it. Well, it doesn't involve very much. Just, collect a few numbers. And of course, you find out as you go forward, oh, that's my responsibility too. There's really no job description, and there's no extra pay. But we're inviting you to take this on. And so what happened was I used to use a quote by Lily Tomlin, which is, we're all in this alone. And it was it was a pretty lonely job at that point. And I felt in many ways that I was a ray of sunshine coming in to see people to say, I'm from the government, I'm here to help. So the other thing I want to point out is that one of the things we want to ask ourselves today is, how are we doing? I call this Antibiotic Stewardship 2.0, given that technically you have a program in place, given the new conditions of participation. So let's see where we're going. But it may be early to be calling it 2.0. I'm being optimistic because this really is a new program for people. The other thing I wanted to point out, though, is one of the things that stands out in terms of assessments that were done recently by the Maine CDC, and this goes back a few years, is not so much practices, in other words, people performing hand hygiene, but our ability to evaluate, are we doing a good job? So we're going to talk a lot about that. You've got this policy in place. You have the sense people are doing it. Can you prove it? And I'll tell you one way that we used to try to prove it. I'd go into a facility and ask the infection preventionists, how do you think they're doing with hand hygiene here? Oh, they usually wouldn't say, I think it's pretty good. They'd say, well, I hope it's pretty good. And I'd say, well, how are you evaluating it? Well, just as I go through the units, I take a look to see what's going on. And the standard quote from the QIO, you can hold on to this one, you probably know it is, hope is not a strategy. So we're going to come up with some evaluation strategies today, other than hoping that we're doing okay. I'm going to have to figure out a way to come over here. So here are our objectives for today. And before I start, how many of you are long-term care medical directors? Any folks that are, so 1, 2, 3, just a few of you. And how many of you are, and for the medical directors, how many years? So keep your hand up. hold your hand up if it's more than a year. And hold your hand up if it's more than 2 years, more than 5 years, more than 10 years, more than 20 years. Okay, so we've got people with some staying power here. How many of you are facility administrators? What? Okay. And more than 5 years? Okay. More than 10 years? No. Okay. And how many are directors of nursing? Oh, quite a few. And keep your hand up if it's more than a year. Oh, total years of experience. And more than 5 years. Keep it up. More than 10 years. More than 20. Okay. More than 30. All right. I think we've got the most experience up in the back, so we're gonna head up there. And how many of you are infection preventionists? Great. And keep your hands up, because you're the people that I really want to see. How many of you have just been assigned the job this year? Okay. So that gives you, how many of you have more than 5 years experience as an infection preventionist? Okay. More than 10? Great. 20? Great. Okay. So a lot of turnover. I'm not telling you anything you don't already know. But we're really going to talk about the impetus for antibiotic stewardship. I know I'm preaching to the choir. We're going to talk about the new CMS conditions of participation, I call them. Some people call them the requirements for participation. Tell me if I'm wrong, but my understanding was those two things are the same. Okay. And then talk about some strategies that might be helpful. And one of the things I really want to talk about, in addition to strategies that relate to the technical work, are strategies that relate to what is the culture in which you practice, and how do you have to make sure that you're practicing in ways that will take advantage of the strengths of your culture in your facility, or help to develop some changes in your culture to make things move along better. The other thing I want to make sure that you're aware of, and you probably are, given that you had to go back a little bit to do this, it's gone back a couple of years, your work in this area, is that there are loads of resources out there. And I put a lot of resources at the end. There are huge numbers of resources through the American Medical Directors Association. And I'm going to point out to you a document specifically from them that if you don't have, you should, that came out in 2017 and is a template that their organization created for developing policies in antibiotic stewardship. It's foundational, so you should not be reinventing the wheel. Those policies are there, and you can make them your own, and it gives you links to everything on the internet. So stop by and see me if that's a reference you need, but all you have to do is Google American Medical Director Association and do template, antibiotic stewardship template, and it will come up. And you have free access to it, so you don't have to be a subscriber even. They've made it available to you with hot buttons throughout. So next slide. This is just a quick outline. You can move ahead on this. This is basically following the objectives. But I want to tell you a little bit about who we are and the QIO briefly, because I know that for some of you, you've never worked with us before. So I actually work under government contract, which is through CMS, Medicare. And I like to tell people now that not only do I work for CMS, I am a customer, just like the hair club for men. It's kind of nice to get that red, white, and blue card in the mail. So the QIO program has its roots in Social Security, and 1965 is the magic year President Johnson signed a bill to make Medicare part of the Social Security program. The new bill went into effect in July, and it expanded the 30-year-old Social Security program to cover hospital care, nursing home care, very specific nursing home care that was skilled, home health services, and outpatient treatment for people over 65. And you know that over time it expanded to include, for example, people who had chronic kidney disease. It seems strange when you think, how did dialysis get included? But they actually, if you go back and look at the legislative history, they actually performed hemodialysis on the floor of the United States Senate. And people were convinced by seeing that. So that really, it was a politically very astute move. And so that group of people is covered as well. And at the beginning, there were organizations that were part of Medicare that were mandated by the law that were called professional review organizations, professional standard review. They tended to basically focus on who they thought were the bad actors out there, the bad performance, so they would go around and look for individuals. They wanted to make sure Medicare beneficiaries were not underused. And this is a cool one, underusing their services. And then a milestone came in '96 when the PROs began to systematically collect data, measure progress, and identify areas for improvement. And this allowed them to shift from auditing records to a much more focus on quality improvement and large-scale improvement. If you've ever heard the expression, he who pays the fiddler gets to call the tune. So if you look at Medicare as the largest program paying for health care in the United States, they realize that we've got a lot of power because we can ask for things to improve things such as cost and look at them at a grand scale. And that's basically what happened, and that's how the quality improvement came into focus. So basically in 2002, we were renamed QIOs. We love abbreviations. Quality Improvement Organizations. We're now called QIOs, which is Quality Improvement Network, Quality Improvement Organization. I still say QIO. And we tend to be focused more on a multidisciplinary team that will work with physicians, nurses, administrators, and others to improve the quality of care. We tend to focus, so we're actually called the boots on the ground for the Medicare program. And every state had a QIO. The reason that anybody have an idea why I have a carrot up there and a stick? So we're the carrot people. I just want to make sure you understand that. We are non-regulatory. So we don't come in to inspect your facility. We come in to invite you to work on improvement projects, okay? So it's totally by invitation. And I can tell you frequently that the work that we're doing today is what I like to call a preview of coming attractions. So oftentimes what we're working on, Medicare is thinking about implementing as part of your quality improvement metrics down the road, okay? And that's us. The other thing I wanted to point out is that the QIO program was one of the largest federal programs that's dedicated to improving healthcare quality. And I like to describe the areas that we focus on are safety, makes sense, right? Effectiveness, efficiency, and I should have these memorized, patient-centered, timely, and equitable care. And we get our marching orders now every 5 years from Medicare. It used to be every 3. And their decision about what we should focus on is almost a lot like, if you look at it as analogous to your annual facility assessment, which you just started to do, which kind of looks back over the year and says, where do I need to make improvements? Where do I need to keep things as they are? How am I going to plan for what the program is for next year? Our program gets its marching orders from HHS, who looks at what's going on nationally and says, you know, what's high morbidity and mortality? What are the things that are killing people? And do we have the opportunity to make improvements? What are the areas that people are suffering from with chronic condition? What's coming down the pike that's going to cost Medicare program a lot of money? For example, diabetes, type 2 diabetes. That's a big part of what we're doing right now, because if we can even help people hold it off for a few years, we'll improve their health, but we'll also help the coffers of the Medicare program for a few more years. So that's basically where we are. And if you can, oh, thank you. We're now working in a regional approach. I used to work for an organization called Northeast Healthcare Quality Foundation. Some of you may have heard that a few years ago. We had the contract for Maine, New Hampshire, and Vermont. Then the new contract came out, and they said, we want you to regionalize even more. So we brought in all of the 6 New England states. And that's us, the New England Quinn QIO. And our contract was running from August of 2014 to July of 2019. So next slide. These are the projects that we're currently working on. I want to tell you that typically we work with providers, but our diabetes self-management program, we're actually working directly with beneficiaries in that one, which is a wonderful opportunity to go out and meet, as I say, real people. But basically, we train non-clinical people to be trainers with groups who actually work with folks in an 8-week program to come up with strategies for improving their outcomes with their diabetes. So they come up with their own plans every week, create some short-term goals, and look at ways to make small changes in their lives that can have a big impact on how their diabetes does. And we've actually got some clinical measures that we've collected on that. It's been very exciting to see the progress of people who have an A1C of 10 come down to within normal range. So that's pretty exciting work. But those are some of the projects. And you can see C. diff reduction is one of the ones on there. And antibiotic stewardship. We're really also focusing a lot of our work on antibiotic stewardship in the outpatient setting, because that's 80% of antibiotics are prescribed in the outpatient setting. So that's really an area where we have an opportunity. And this is the current project. So from 2016 to 2019, what happened was the CDC did a field study back in the early 2000s, like 2012, so mid-2000s, where they picked 9 regions around the United States, and they said, what does C. difficile look like around the country? Historically, we had always thought of it as a hospital problem, but this study showed that it was much beyond that, and we were also seeing a lot of it in the community and a lot of it in long-term care facilities. The problem was we didn't have any data for long-term care because there was no repository for data. Hospitals were already reporting their data through a national database called the National Healthcare Safety Network, or NHSN, and they're doing that as a mandatory requirement now. Since 2005, they started to use that. Nursing homes, we only had about 200 nursing homes, I think, using that system because it was voluntary. And you all know what that's like. I'm not taking on the voluntary stuff. I got too much already. So they invited us to come in and select some facilities, invite you to work with us. We had to figure out, well, who do we pick? And CMS said, well, go pick the nursing homes that have a C. diff problem. Well, the problem was we didn't have any data. So we tried to come up with what would be a proxy. We ultimately came up with guilt by association. So in other words, if you're in a region where the hospital has a lot of C. diff, we're going to ring your doorbell and say, you want to work on this great project? And there was probably accuracy to that, because you're seeing the same people that they are. They're diagnosed here and they're diagnosed there, and it's a revolving door, correct? So I think that we probably ultimately hit our numbers. There are now over, I want to say, a couple thousand nursing homes. What have we got? What did I have here? Well, there are 7,000 in the collaborative, but I think in the C. diff project alone there are 2,000. So we're getting good data about C. diff across the country. And people are also learning how to use this National Healthcare Safety Network, which I'll put in a plug for. It's a wonderful surveillance system available to you at no cost. All you have to do is have a computer that's connected to the internet pretty much, and you can get secure access. You're entering your data over a secure site, and instantaneously you can analyze your data and compare it to the national data across the country. So if anybody wants more about that or wants a private tutorial, I'm happy to help. But right now we've only recruited 15 nursing homes in Maine to work on that project. Next slide. So let's start by talking a little bit about the epidemiology of HAIs and then move into stewardship. Please interrupt me too, because you can see I talk. But I can be interrupted easily. So these are all things that you're familiar with. We're looking at, large numbers of infections in long-term care. These slides will all be available to you, so don't worry about writing anything down. Also, I think we know that infections are a big cause of hospital readmission, and we're starting to look at that issue of the cost of patients going back and forth to the hospital, and specifically looking at coming from long-term care. We know they're a cause of great morbidity and mortality, and here's the list: UTI, lower respiratory, skin and soft tissue, and gastroenteritis. So people always say, well, where do I start looking at antibiotic stewardship? Try to pick one thing and jump into it. And if you think that it's UTI in your facility, that's a tough one, but it's not unreasonable. And you can get a lot of bang for your buck, even if you work around small pieces of it and keep adding to it. So think about that. Where do I have my biggest opportunity to make improvements? Next slide, please. So here's the other big problem. 50 to 75% of people in long-term care get an antibiotic every year. So they get a lot of antibiotics. The burden is heavy. And we know that upwards of 75% are either inappropriate or totally unnecessary. So that's a very important statistic. We've got a problem. We're overusing antibiotics. And we also know, and I put topical here, but we're not going to really be talking about topical. So now that I mentioned topical, put them over here. And we're going to focus on systemic antibiotics. So next slide. And here's what the problems are. Number one, they're given when they're not needed, just in case sometimes. So we want to look at, opportunities for making improvements when they're used, for example, when the illness is most likely not an infection, that with a bacteria, it's viral. We would all agree that that would be inappropriate. That they are often continued longer than they need to be. The length of treatment. We have some new data on treatment length, and treatment length has been cut down considerably. And every day that treatment goes on, the person is at risk for more complications. I'll just tell you by way of, this is a little caveat. We had a program, and I'm not just throwing salt at your wounds. The hospitals have already been dealing with this for a while. One of the projects you may know if you're involved in hospitals was the SCIP project, the Surgical Care Improvement Project. One piece of the SCIP project was administering antibiotics given certain surgeries at a certain time before the incision was made. And we know that it had to be within a window of time. And it was really just a single dose. The problem was when SCIP started, people didn't turn it off. So that dose would be given in the OR, but then the person would go back to the unit to recover, and they'd keep getting the antibiotic. So you realize that there are things like that are sort of procedural, that you really have to make certain that there's a way to start it and there's a way to turn it off. Because we were actually, in some instances, we're seeing problems with C. difficile as a consequence of that. The other issues here, they're given at the wrong dose. Their broad spectrum agents are used to treat more susceptible bacteria, and the wrong antibiotic is given to treat an infection. So in terms of the work that you've already done, and you tell me, anybody here want to speak about anything that you're doing related to any of these issues? Anybody want to talk about that? That you've addressed things like amount of time that somebody's on an antibiotic. That's a good project right there. You know, making sure that you're following the guidelines for how many days of treatment. The other is empiric therapy. You have a patient who's got signs and symptoms of UTI. You sent off the urine for culture, but you want to start treating them. How do you decide what drug to choose to treat them with while you're waiting for that result to come back? How many of you here get something called an antibiogram from your laboratory? Okay, and I should see every hand in the room go up for that. Were you going to?
Well, first of all, the antibiogram comes from the hospitals usually, so if you have any link to the hospital,
yep.
They issue. But one, you asked if we're doing anything, and I'll just wanted to mention that we addressed the UTI issue by addressing the testing.
Okay, good.
So if we stop abusive testing, stop wasting antibiotics.
Yeah. And that's been a tough one, but that's crucial because what happens when you get back a lab report? You got to do something with it. So the key is anytime you order a lab test, you already need to know what you're going to do with the result before you send it off. And if it's to do, that's interesting, don't do it. The other issue that relates to that, besides just culture, are things like dipsticks. I can tell you that the recommendation now is take them out of your facility. Good. And if you have them, talk to your administrator about removing them, because that has also been another impetus for sending off or starting to treat somebody with a positive dipstick. And we'll talk some more about that. But those are two big opportunities for wins right there. See what happens. The other thing with the antibiogram, I'm going to put in a pitch because I worked for a lab. And remember, this was started 20 years ago. We were able to produce an antibiogram for every nursing home that I went to. So if the hospital is telling you that they can't do it, you go back to them and tell them, gee, you managed to create a bill for each patient at my facility. Aren't you able to collect the data that relates to my patients specifically? Because I can tell you that they can. And we could do it for no matter the size. For small facilities, it's challenging because you don't have enough isolates. You have to have at least 30 isolates of a type. So in other words, to run an antibiogram on E. coli, you would have to have at least 30 isolates. My guess is almost every facility would have that one. And you're probably only going to be able to run an antibiogram on urine isolates, because that's the major thing that you're doing cultures on. But that's all you need. So I would go back to the lab, and believe me, I'll help make that case with you. Their whole system is computerized, so they can pull out your data and create a report. The other thing I recommend to people is if you have an infection preventionist in your facility and you get microbiology reports over a report printer into your facility, they should send a duplicate copy of every report to go to your infection prevention person, so that they're not getting them just at the end of the month. They're getting them every day as the reports come over the printer. Okay? And we actually had them set up so that the second one said, infection control copy, so that the people on the unit would sort them into a box for the infection control person. So we'll get that taken care of. So here are a lot of the issues here, and I'm not going to go into them all, but every single one of these gives you an opportunity to come up with a project that you want for improvement work. So chip away at it. The other thing I want to point out is, well, I'll come back to this. Oh, I did want to point out to you something here, and that is, how many of you see this treatment for urinary tract infection prophylaxis? People on long-term. So anecdotally, what I'm hearing is, I'm going to point the finger. This comes from urologists. Yes. So I think we have an opportunity. I'm going to put this on your medical directors to take on the urologists on this one, because the practice in many instances is outdated, and it's an opportunity for a conversation. But remember, as you do this, you can really feel like you're on a crusade, because antibiotics are the one category of drug that when I'm taking one and I'm living in a nursing home, it's going to have an impact on the guy in the next bed. So remember that. The only category of drug that has that impact. So I don't want you, if my mother's in that next bed, I don't want you developing all these resistant bacteria to spread them over to her, because I'm kind of selfish that way. The other thing, what do you folks know about treating asymptomatic bacteriuria? In other words, going for a culture, even though that resident has no real focal symptoms of a UTI. In other words, they may have a little temp but nothing else, or maybe a little confusion, and you say, oh, I know this is a UTI, and you're treating them. What do you know about that treatment? Is it going to improve their quality of life? No. We have no evidence that it's going to make them live any longer or live any better.
It makes the daughter feel better.
Yeah. But you brought up a good point here, because when we look at the culture of prescribing, and one of the things physicians will say was, well, I got pressured by the family. What can you do? What can you do about the family? And when does that happen? Not in the heat of the moment. It should happen the day they arrive. And you've got posters everywhere saying, here's our philosophy here at Happy Valley Nursing Home. Every physician there has signed the poster and says, we're committed to make this an antibiotic safe facility. And everybody gets that in their packet of materials, and they get a flyer that says, here's our philosophy on antibiotic use here. You don't want to wait until the daughter's breathing down your neck saying, Dad always gets this, and every time, I don't know what's the matter with you, because he needs that, right? I mean, they need the education as much as your staff does. Lots of materials online. You don't have to recreate the wheel on this, okay? The other thing I'll point out, this was a research study done in physicians' offices, okay, by a group in Boston, Brigham and Women's. They looked at, they had clinics in areas around the country, and they put up commitment posters. Physicians signed them saying, I commit to making improvements. And they actually saw, just based on signing those commitment posters, that their prescriptions went down. Usually we like to talk about rational interventions. This is more of a what the literature refers to as a cognitive nudge. And what it does is that if I sign a paper that says I'm committed, by God, I'm going to start acting like I'm committed, right? And that appears to be a piece of it. I want that paper that I sign to represent who I am. I don't want it to be phony baloney. So that's a wonderful study to look at. Simply hanging up those posters had a huge impact. So next, this is more of the same, but programs that will address these things: selection, dosing, route, duration. So keep going. The other thing I want to point out to you, by the way, is that in New Hampshire, around selection of empiric therapy, our New Hampshire Public Health Department at the state level, because I was in New Hampshire up until March, we did a state antibiogram with all the hospitals, 26 in the state, and it's online, and so you can look at it. One of the things that was very interesting, people really tell you to use a local antibiogram to reflect what's going on in your facility. Interestingly, we found that this statewide antibiogram was very consistent with what people were seeing in their local facilities. Even Dartmouth-Hitchcock, which is a tertiary care center, said they thought it looked terrific. And so they're advising people to use it in some respects for empiric treatment. And online, you're going to be able to look at, just Google it, New Hampshire Public Health Department Antibiogram 2016. It came out in 2017. But they gave recommendations. They gave recommendations, for example, for empiric treatment of UTI. And for example, they were able to show that what's the drug of choice for empiric treatment of urinary tract infection in your facility? You should know that right off the top of your head. And don't tell me it's a fluoroquinolone, because it should not be. And because of the black box warning that came out a couple of years ago, unless it's complicated UTI. And they showed that nitrofurantoin, the old furanantin, was at something like 98%. The largest number of isolates, something like 25,000, were E. coli in urine, and they were 98% effective with furanantin. So it was a good choice empirically. The odds were that you were looking at E. coli, and the odds were that furanantin was going to treat it until you got that culture back. So take a look at it, because it's very well done, and it gives you a notion of how you create recommendations based on your antibiogram. So here's the background. I just want to point out, anybody here know who that guy is? It's a trivia question. Alexander Fleming, creator of, or the finder of penicillin by accident. And Alexander Fleming said he discovered it in 1928, and shortly thereafter he said, "The time may come when penicillin can be bought by anyone in the shops. Then there is the danger that the ignorant man may easily underdose himself, and by exposing his microbes to non-lethal quantities of the drug, educate them to resist penicillin." Pretty prescient, is that the word? So he was talking, and we knew that within a few years after penicillin came onto the market, it was resistant, lots of things. And on we go, so we kept coming up with new things. If you've never looked at this document here, go back and read it, because this is kind of the precursor in the United States. There are a lot of evidence that was assembled, but this antibiotic resistant threats in the United States, 2013. What's amazing about it is, I usually think of the people at CDC as being very measured in their talk. They sound almost hysterical in this. I mean, if there's such a thing. I mean, they're really raising the alarm. And they describe the threats as, I think they were urgent, serious, and concerning. And they talk about what their strategies for each one. The urgent threats were CRE. Some people here may have already seen this because we're seeing it in long-term care. Neisseria, I never can say this right, gonorrhea, drug-resistant gonorrhea. And the last one is C. difficile, because what we've seen is the numbers haven't come down the way we want. Serious was the ESBLs, and then concerning onward and upward. But They really talk about the fact that 2 million Americans are infected with these, 23,000 are dying every year. And what happens with these emergence of resistant organisms because of antibiotic pressure is that we're having to give people more toxic drugs, more money, and less effect. So next slide. Oh, and the last one, National Strategy to Combat Antibiotic-Resistant Bacteria. This is a report that came out from President Obama in 2014, and he spelled out basically what the action plan should be in the United States. Very fine document, and it's worth going back and looking so that you'll know where your program has its roots. I just like these cartoons, and I would suggest to those of you, a lot of you I think are doing infection prevention and doing education, that there are so many wonderful materials from the CDC and these kinds of pictures that really can capture the whole issue of resistance. This is resistance as a result of natural selection, right? So, I used to talk about, when I first started talking about C. diff, that C. difficile is not part of our normal flora. And usually our intestines are so filled with bacteria and bacteria that have taken up nice residence there that there isn't any room for C. diff. But the minute we start hitting them with antibiotics, treating like a strep throat or whatever, it's going to kill some of our normal bacteria. It's like vacancies in the apartments. And now there's room for C. difficile to find an apartment to move into. And that's basically what it is, finding a new home and a niche that wasn't there before. So there it is. Next one is really looking at one of the things in New Hampshire at the statewide HAI program we have is what's called a One Health program. We're working with not only healthcare providers, but we're working with the state veterinarians, and we're working with people who are involved with feed animals, because we know we're all in this together in terms of the pressure of antibiotics on the food supply that it crosses over to us back and forth. This is the goals. Most people yawn when we say decrease costs, but we really want to look at the health effects and the toxic effects of antibiotics as well as drug resistance. So go on. I've got to look at goals, but you want to make sure you've got your goals in your policy statement. And this is a list of goals that include, and the basic goal is improve patient safety, right, around treating people with medication. And I'm not going to go through those. I gave you that list, and you can select what you want to work on there. Next slide. Here's the CMS. So it requires you to develop a program, and I believe it was 2016 in November that you had to have your first go-round on that. Is that correct? Yeah. And you remember that the conditions of participation have been factored in over 4 years, and that you should have antibiotic protocols and a system to monitor antibiotic use. Everybody has that in place? You have the policy statement? Good. Okay. And for those of you who are infection preventionists, you want to take a look at this, because one of the things that you'll be doing is working on sort of developing that plan for next year pretty soon of what you want to focus on. So get it under your belt in terms of what you're seeing right now. You always want to start with the baseline. Next page. And again, this is more on the stewardship. So protocols to optimize treatment, that it's appropriate, that you're reducing adverse events, and that you're getting a system-wide program to monitor the use. More of the same. So I want to give you some results, and this is from the Maine CDC. Some of you may remember taking part in this. The ICAR is called the Infection Control Assessment and Response Program that came out of the Ebola program, basically, in 2014. Remember the Ebola in West Africa? We actually saw 3 domestic cases of Ebola, and so the Public Health Service was challenged because we thought we had some vulnerabilities that we needed to attend to. So federal funds were given to public health departments across the country to identify gaps in our infection prevention systems. Any of you remember taking part in this assessment, the ICAR? And if you don't remember and you're new, ask somebody when you go back to the facility. So you may not all have these reports, but a large numbers of you do. Go back and look at the data, because it's going to give you it's a wonderful assessment of, I believe it's 9 categories of infection prevention, and it can be very useful when you go to do your annual facility assessment to have an ICAR assessment because it covers the boardwalk. You know, it looks at the infrastructure of the program. It looks at healthcare personnel and resident safety. It looks at surveillance systems. It looks at hand hygiene, personal protective equipment. Are we doing it? Are we using respiratory hygiene? The stewardship program is addressed. Maine actually conducted assessments between May of 2016 and August of 2017. And I've got Jen right here who can correct me, and I invite her to if I don't get this right. There were 24 assessments done. Interestingly, what they found was 63% of facilities had a trained infection preventionist. So you had a number of folks still that the person still needed to get some training, but I know that this has improved even since here. And that piece that required training has to be completed by November of next year, 2018. 19, sorry. I'm a year behind. This is 2018 now. 2019, the infection preventionist has to have formal training. So you've still got time, and there's lots out there. So I just wanted to point out to you to go back and look at this, but some of the things they saw were opportunities for improvement. I just want to point out to you here that this area, hand hygiene policies promote preferential use of alcohol-based hand rub. One of the things we found was that people didn't realize that they really needed to make sure that the key hand hygiene method is alcohol, not soap and water. I mean, you use soap and water, right, if your hands are visibly soiled. But for the most part, you're going to use alcohol. So that's crucial that you identify that if it's in your facility. The other areas, and actually if you click that, I think some markers will come up. Yep, and go to the next one and the next one. Right. The next one that started is that the facility routinely audits PPE use and adherence. That was an opportunity for improvement. It was only at 19%. That people were actually going out and looking and saying, how are we doing? And that they were giving feedback to personnel on the unit. Next one, please. And then this is PPE. And again, if you look at this one, what we have here is monitoring PPE use and adherence. It was only at 19% and giving feedback to people. So both hand hygiene and PPE. And then the last one I want to point out is antibiotic stewardship. And again, we have some opportunities. Actually, next. Keep hitting it. And yeah, next. That's it. And what we have here, and actually we can click this like 4 times. Yeah, one more actually, because these are all the areas of stewardship. There were no policies at the time that this was done. 7%, 15% didn't have. Only 15% had a report summarizing antibiotic use from the pharmacy. The lab drug and resistance report. So a lot of these have improved, and I want you to flip ahead, skip the next slide, and go to the next one. And this is the core assessment tool. How many of you use this in your stewardship program? Core assessment from, and if you're new to infection prevention, what you want to do is go on. I've got the reference at the back, but the CDC in 2016 in November came out with the core assessment for antibiotic stewardship in long-term care. This was the second or third document. They had one for acute care hospitals, one for doctors' offices. This is specifically for long-term care. The other thing you want to do when you print that out, and this should become a Bible to you. So you want to print it out and put it in a notebook and copy out all the appendices that go with it. Because each appendix will bring you to materials that you can click and get in terms of tools to collect data on. You don't have to be creating anything. All the data collection forms are there as part of those appendices for the core elements. And they actually come out with what are the main areas that you want to look at in developing your program. This really, hang it up as a poster because you need to keep going back to this and developing these areas as you go along. So yes, 5 minutes, boy, I'm telling you. As the saying goes, if I had more time, I would have written a shorter letter. I want to point out to you, though, that things have improved. So this was the first time it was done, the blue, 2016. And the orange is 2018, okay? So people have made improvements. And these are people who have met all 7 criteria. We still have a ways to go. And you want to make sure that you're touching on something across the board. The leadership commitment really is getting people on board to deal with this. Getting your medical director on board because they're going to be the key. The pharmacist going to be key. The administrative staff, the infection preventionist should sit on a stewardship committee. And it's not a bad idea to have some representations from the rank and file. So, you know, I always say for those of you who, and I know it's hard in long-term care now because the supply lines are pretty slim. But for those of you who are working as the infection preventionist, find a disciple on one of the units, somebody who loves infection control, that you're going to say, I'm going to take you under my wing, and I'm going to support you to make this a specialty area for you. And they can be your eyes and ears on the unit because you can't be everywhere. So it's very important to have those representatives. That was actually a model for doing infection prevention in hospitals. People would have disciples, I call them, on every single unit to be on the lookout. Next slide. So we're making some improvement. I also wanted to show you this. This was, we asked people to just raise their hand if they knew what they were using for C. difficile laboratory testing. And 50% of the participants were unclear. This is crucial because if you don't know, people could be, and one of the problems with C. diff testing right now is because so many people, how many know that you're using PCR testing? Okay. But a lot of people here aren't really sure what you're using. So that's going to be your first assignment is to go back and call up your microbiology lab and say, what's the test? Or look on a lab report. And then I want you to get the guidelines from SHEA that just came out this year. SHEA and IDSA came out in February. Just Google it for C. difficile because there have been some changes. And one of their concerns is that they're finding that people are doing too much testing. And with that test, that PCR test, because it's so sensitive, you're going to end up identifying colonized people. But what they found was as many as, for example, 25% of the people that were being tested had had a laxative within the last 2 days. Well, you don't want to give those people this test, right? And also, you want to make sure that they're having diarrhea of a certain kind. So if you move to the next slide, Well, I have it coming up. How many of you are aware of the Bristol stool chart? So it's pictures of poop, basically, that you can hang up, and it will tell people, unless you get a number, you know, people start to kid about it, like, what number are you today? I'm a 5, you know. Uh, but it has to be liquid stool, and people need to know what liquid looks like. So this is a very good one to start with. You don't want to be over-treating this because it's a problem. The other thing I would throw out to you, and this is kind of scattershot at this point, but if you have, and I'm seeing this in long-term care facilities, if you have residents who are having recurrent C. diff, and I mean multiple, and where we see it is long-term care because people are there for a while, they should be evaluated for fecal transplant, okay? That is in the recommendation. And I can tell you that there are places in Maine where they're doing it. I believe, you know, as the infection preventionist, you want to try to track down those sites. The ick factor is gone. In New Hampshire, we have people getting their stool from a stool bank. And some brilliant kid from MIT whose mother had C. diff developed a stool bank where people will get screened and they can contribute their samples, and it gets sent frozen to you, and it's given through endoscopy. So you don't even see the stuff. And there's pill forms now. But if you have patients who are suffering constantly and aren't getting relief, that's something to advocate for. That's in the guideline. So next slide, please. I'm just about done. I'm going to get the hook, right? 3 seconds. All right, so I'll move on. This is the thing I want you to think about, the difference between the technical aspects and the cultural aspects in your facility. Do you ever hear the expression, culture eats strategy for breakfast? Yeah. So remember that. And one of the, just flip to the next slide, and then I will leave. So here's what I wanted to point. This is nurse-physician communication. Here's a cultural aspect, something that you want to work on that's not just stewardship, but it's going to have an impact on the whole process. How are we communicating? Okay? We all know that we have a long history of being at cross purposes. Nurses speak in a narrative. We love stories. Physicians are like Sergeant Friday on Dragnet. Just the facts, ma'am. I want the facts, right? So there's a difference there. We communicate in different ways. So here's an example. They did this study of looking at nurses and their communication in long-term care, and they interviewed them with both quantitative and qualitative. I love the qualitative interviews, so they asked for more detail. They said they often felt hurried. They felt that they had no quiet place to go to make the call, and they also found that it was very hard for them to reach the physicians, okay? That's just one example. So go to the next one, and this is what I want to speak to you about. How many are using SBAR communication? That's wonderful, okay. And are you using it in a way that, for example, UTI, you have a document that tells you exactly what you should be looking for? Because there's an SBAR form specific to UTI. And that is a great one to start with, because what it's doing is it's getting you to collect all your ducks and all your data before you pick up the telephone, okay? So that you're going to speak in the language that physicians speak in, which is just the facts, ma'am. Quick story. Here's a trivia question for you. What is the root of SBAR? Where did it come from? No. The submarine service. It's from the United States military. And if you can imagine how quickly, if you're in a submarine and you're running into trouble, you have to make a change in course. SBAR communication was critical. And then it was used in aviation. You remember the Miracle on the Hudson with Sully? He used SBAR communication because he had to have it precise. And I would invite you, if you're doing SBAR, that's great. But if you want to zero in on specific items like UTI, this will give you the template for that, okay? I'm going to stop here. I have tons of references at the end. I apologize for talking too much, but we'll do it another time. And please call me if I can be of any help, I'm assigned to work with a group of facilities, but I go anywhere that I'm invited. So thank you. And my name is at the end of the slide.